I'm Joshua from Hong Kong. It's really our pleasure to have distinguished speakers for today, and welcome all of you to APASL Hepatology webinar, Episode 4, during this difficult period of COVID-19. And today will be Session 1. And the speakers, as I have mentioned, is Professor Shiv Sarin, who is a Senior Professor in Hepatology and Director, Institute of Liver and Biliary Sciences in New Delhi. He was instrumental in the setting of Institute of Liver and Biliary Science under the auspices of governments of Delhi. And he is also director of the WHO Collaborative Center of Chronic Liver Diseases. He has more than 600 publications to his credit, edited 13 books on liver diseases, and contributed 87 chapters in various medical textbooks. He has been awarded with the Henry L. Boscus Medals in 2017 by the World Gastroenterology and Organizations, and also the Padma Bhushans by the governments of India. He is a recipient of the Shanti Swab Bhatana Award, the World Academy of Medical Sciences Prize, and ESO International Recognition Award, and also the Rambasi Medical Science Award and the Best Teachers Award, besides being the founding editors of Hepatology International, our official journals for APASL. His contributions is well recognized worldwide and do not really need these introductions. And he developed with other boards of the governors the visions of 2015 documents of the medical educations in India. So without undue delay, I would like to have Professor Sarin to deliver his talk today relating to the variceal bleedings and the portal hypertension. Professor Sarin.
Thank you, Professor Lau. It's a great pleasure, and I know I am working as a Stepney here. The original talk was by Dean Jensen, but Dean was not available, and therefore I stepped in because the program as planned by our president and by Professor Lau has to go on. I do hope I can do justice. I bring greetings from ILBS, the Institute of Liver and Biliary Sciences, New Delhi. I do hope my videos work. Otherwise, I will switch on to my videos from my computer. Next is.
Sunny.
I have no conflict of interest. I will try and give you some brief idea about the portal hypertension, an area of great interest for me. Next slide, please. How to diagnose portal hypertension? Well, presence of spleen, ascites. You can diagnose it so easily. Also, in a cirrhosis, if the platelets are less than 100,000, AST to platelet ratio is high. Ultrasound or CT shows portal vein, spleen, collaterals, or a fibroscan value of more than 23 is very suggestive of portal hypertension. However, you really still need to do endoscopy, and to be sure, like you have a patient with blood pressure, you need to know the pressures. You will like to know what is the actual portal pressure. Next. Now, this is the balloon catheter. We are actually not getting balloons, so a simple Swan-Ganz catheter. This can go through the femoral route or through the transjugular route. And once you are in the hepatic vein, this is right hepatic vein, and you can have this balloon inflated, and then you see that the wedge pressure comes. So this is wedge pressure. In this patient, it is 32. When you deflate, the free pressure is 11, and this is consistent in two readings, and the gradient therefore is 32 minus 11, that is 21 millimeters of mercury. Next. So let's look at the normal splanchnic circulation. You have a splenic vein, you have the superior mesenteric which formed the portal vein, and once the portal vein is there, it goes into sinusoids where the hepatic artery comes, and then it has an exit through the hepatic veins and then into the IVC. You can place a balloon Next, please. You can place a balloon, as I said, through transjugular or through the femoral route. This balloon will give you the wedge pressure as I showed you, which normally is 6 to 12 but can increase in liver diseases. And you remove from this the free and you get the hepatic vein pressure gradient. So wedge minus free. Normal is 4 millimeter. Anything above 5, as you can see here, anything above 5 will show that it is portal hypertension, and if it is above 10, then clinically significant. It can have varices, it can have ascites and other complications. We do close to about 1600 HVPG through the femoral route and about 650 every year from the transjugular route. Next, please. Now, this on your right hand side, you see a scale 0, 12 millimeter and above. Up to 5 is normal. 5 to 10 is subclinical portal hypertension. 10 to 12 is clinically significant portal hypertension. Once there is clinically significant portal hypertension, you can have ascites, hyponatremia, all complications. On the other hand, you can have varices, and if it goes above 16 millimeters, there is variceal bleeding, portal hypertensive gastropathy, spontaneous shunt, hepatic encephalopathy, and others. So now you need to know on the parameters, the higher the pressure, more are the complications. Today we are mainly discussing about variceal bleed and its complications. Next. So our aim is to measure the pressure and reduce the pressure and prevent the complications. Next, please. How do you manage the complications like acute variceal bleed and uncontrolled bleeds? Next, please. Every year we see this is AGIB, is acute GI bleed. Every year we see close to about 900 to 1000 acute variceal bleeds for last few years. And this means that this is not uncommon, in the winter especially. Next, please. This slide is important to show you while the numbers have increased. I could get the data up to 2016. Mortality, which was initially sometimes 17-18%, is about 13% or so. But it also means that we still lose 1 in 10 or even more patients due to bleed. And we should not. In a liver unit, in a specialized center, why should you lose? So there are causes. Next, please. Here is a typical bleeder. Now you can see the pressure in this maybe more than 20 meters. It's like a jet. 1, 2, this is the AGA teaching slide. This is the nipple sign, and these are the variceal bleed. So there are several types of bleed. One is that with a nipple sign, recently bled. These are called stigmata of recent bleed. Here is a spurter, actual spurter. Here is a band, EVL ligated, and then you have a clot which has recently bled. Next. There are two guidelines. One is of the Bevino 6, where you have this, and one is from APASL. This APASL is management of AVB, just acute variceal bleed. And then there is a guideline from Bevino, which is comprehensive for portal hypertension. I recommend you to read both. There is a difference. Next, please. What the APASL guideline says, unlike the Bevino, is that acute bleed is 48 hours and it is divided into two. This division is not there in Bevino. One is an active. I showed you a spurter. Active bleed. And one is an inactive. Patient bled few hours ago and has come to you. And from time 0, that is the time the patient comes, to 48 hours, this is acute bleed, and this is based on endoscopy. And then is rebleeding. This is after 48 hours. While In the Bevino, it is after 5 days. We divide it into two, very early, 48 hours to 120 hours, early up to 42 days, and late is after 42 days. There are two important concepts given at the bottom. Door to needle time. I'll come to it again, and door to scope time. Next, please. So here is our management updated guidelines which I have prepared. This is based on the initial consensus. Cirrhosis with acute bleed. Door to needle. He comes to the emergency door. To the time he gets terlipressin, somatostatin should be less than 30 minutes. Then you are able to control the bleed fast. Or give at that time PPI, antibiotics, and acetylcysteine, and try to keep hemoglobin around 8. The next is door to scope time. This has to be done so that endoscopy possibly can be achieved in 6 hours to prevent further bleed. If the patient has successfully got banding and bleeding is controlled, he goes on to secondary prophylaxis after 5 days. If the bleeding is continuous, persistent, or rebleeding is early, then this patient needs a repeat endoscopic therapy or maybe early tips. This is new. Earlier, everyone would get a repeat endoscopy and no early tips. Now, early tips, I'll show you why, is important. If there is failure to control or rebleeding, then you can have a rescue therapy. This is repeat bleeding, early rebleeding. Here, there is failure to control. Now, very important is what is to stratify APASL bleeding risk score. This was developed by APASL and is very popular. I recommend you to read that. Stratify your patient whether he will stop, he will continue, or he will bleed to death. Next, please. Now, control of bleed is that at endoscopy you are able to control. And this remains controlled for 24 hours after you have stopped. So you have put bands or you have given combination therapy and it remains like that for another 24 hours. That's control of bleeding. Next. What is failure of therapy? Please understand this concept. Failure of therapy occurs in about 15 to 20%, and the number of people who die is about 15%. So those who fail are likely to die. So we must know there is fresh hematemesis after 2 hours of combination, means vasoactive plus banding. There is more than 2 gram drop, 6% in hematocrit without transfusions. So increase in heart rate and decrease in systolic BP means there is shock. And of course, we don't want that. The first 3 criteria are there. We need to change our therapy. So what is change of therapy? You have done endoscopy. You find you can't control. Send him right away for Danis, send him right away for tips. We'll come to it in a minute. Next, please. So the first 3 criteria require modification of therapy. What is modification? You have to decompress. Decompress is by tips or another PTVE, percutaneous transvenous embolization and decreasing the pressure, or compress by the esophageal stent. So these are 2 methods which we have to remember. Next. Now, what are the things if the patient comes, can you stratify him right away that he is not likely to stop bleeding? If his pressure is about 20 or like 20, the risk is 11-fold that you will fail. But everybody doesn't do pressure. What we can do, if there is infection, he will bleed like ACLF. Active bleeding at endoscopy. Remember simple formula, active bleeding means the HVPG is above 16 and this patient will bleed. If there is portal vein thrombus or if his child sees cirrhosis. So at least you can assess 4 if not 5. Next please. This is to show you active bleeding at endoscopy, and the risk is about 3 times that you will fail. So if you have such a patient at endoscopy, what will you do? Plan B, have the tips ready. Plan C, maybe Danis are ready. And you have the counseling, everything getting ready. Next, please. Now, this is a very important slide. We all give patients beta blockers. Now, if a patient is already on beta blockers and he bleeds, the risk of failure of therapy are high. It is 2.46 times. So, if you have beta blockers but adequate beta blockade is not there, he is a non-responder, such patients may bleed massively. Therefore, it is important that you measure the pressure and see the response. Now, alcohol or active alcohol, low blood pressure, all these are related to death, but they are in univariate analysis. High MELD score, of course, is bad. Next, please. Now, this is our own data, somatostatin plus band ligation versus band ligation alone. If the pressure is more than 20, then the chance that you will have any benefit of any therapy are unlikely. Odds are high. If active bleeding is there, odds are high. So both these are combination therapy will fail if the pressure is about 20 or there is active bleeding at endoscopy. So whether you do EVL alone or EVL plus pharmacotherapy makes no difference. If the pressure is about 20, active spurter is there. Next, please. Now, this is an interesting paper which shows that if you have continuous versus bolus terlipressin and acute bleed. Somatostatin has a half-life of about 3 minutes. So you have to give continuous. Terlipressin has a half-life of 23 minutes to 30 minutes. But you give every 4 hours. What is the benefit? So people tried continuous versus bolus, and you see that the response rates are much better with HVPG when it is given as a infusion. Responses are higher, responders at 24 hours are higher, and mean dose of terlipressin was lower. This is our own study which is likely to be presented at this ASLD. Next, please. Now I will show you some videos because many of you are very good endoscopists. I don't claim that I'm any better, but I'll just share the experience of 3 things, whether location makes any difference, post-EVL ulcer bleeds any makes any difference. Next, please. This is just to say, and we had one patient yesterday only. This is not, this is an old patient of hiatus hernia with Variceal bleed. Now, this is a tough situation. Will you band such a patient? You may be in trouble because this is in hiatus hernia. This is the gastric mucosa. Don't try to band, inject. Next, please. Now, can you play the? There are 3 videos on this. You're amazing, Izumi. Just play this video. The first one. Click on it. Yeah. Now here is an endoscopy. Sorry, have I done any? Please play again. Yeah. You will see that at the lower end of the esophagus, you have this bleb. This is a clot. This is from a recent bleed, and there is very little space between this and the Z line. In such a patient, don't inject, don't do band ligation. It is preferable to do a hemospray when you have an active clot sitting on a varix which is close to GE junction. Now click on the second video, the top one. Yeah. Here is a patient who has a very active spurter, but you have about 5 millimeter space available below the spurter. In this less than 5 millimeter space, you can't apply a band because you will get gastric mucosa and the patient will bleed. It is better to inject glue or a sclerosant in such a patient. Third video. In this patient, you have much bigger, about a centimeter of space and an active bleeder, and you have space to place a band. In such a patient where there is about 1 centimeter, you can comfortably do a band ligation. The basic message of all these three is in an active bleeder, location matters. If the gastric mucosa will come with your band or glue or anything, this patient then will have more trouble. Next, please. Hence, location matters. Next, please. Now, here is a difficult case. This patient had CTP 11, male of 23, post-EVL ulcer bleeding. How? He came for routine EVL but was cirrhotic and child C already. After EVL, he bled 12 days later and came. So someone did a sclerotherapy with glue in our unit. 4 hours later, he bled again and he failed to endotherapy. Now what do you do in this patient? Here is somebody who has a MEL 23. You will say, wow, what can you do? He will die. Next, please. In such a patient where you have high MELD and the risk of decompensation or HE, you can place something called as a Danis stent. You can also place Sangstaken, but now less often we do it in advanced disease. Danis stent is a stent which comes like a, this is like a Sangstaken tube kind of a thing, and you have this stent. I'm sure many of you are placing it. Next, please show this video. Please click on it. This has not come out so well, but hopefully I can explain you. So here is a patient who has a post-EVL ulcer bleed. EVL was done. This is the stent. Here is the stent which is going inside. It's a self-expanding stent. This is the balloon inside. Here you are able to place the stent well, and after placing the stent you come out, keep it for 7 days or so, 5 to 7 days. The bleeding is stopped and it is very easy. There is a thread there. You can catch hold of the thread and then you can pull it out without any difficulty from the mouth, and this leaves behind an ulcerated area which can bleed again. We'll give you an example. We had an alcoholic guy whom we had done an EVL. He bled just recently till yesterday. Then after bleeding, we put a Danisella. Danisella was removed on the 7th day. After removal, he spurted from the varix badly. Within 2 hours, he got a TIPS done. His pressure was 23, which came down to 10. Then he was stable for 10 days. He went home. He came yesterday, 5 o'clock or 6 o'clock, again with a bleeding from an ulcer which was left, and a second Danisella had to be placed in this patient. But he is stable. He is still having a bilirubin which is 7 or 8. Here you can see that post Danisella, there are some ulcers, but not too bad. Next, please. But you can put Danisella twice or even 3 times. Next slide, please. This at least gives you time. So what I have shown you till now is a patient who has got persistent bleed or he bleeds early, and we have 2 approaches. One is Danisella as a compression. You can also do TIPS. Now if you have a shunt available, that means a gastrorenal or a short gastric shunt, then you can do a balloon retrograde transvenous obliteration of varices. Next, please. And helpful in gastric varices more. Now, can you do TIPS? It can be done as a rescue or can be done now as an elective emergency or emergent TIPS. Next, please. Now, this study, the concept of TIPS came from a study which was in 2000, but I'm showing you 2004 study. Those patients who had AVB and had endoscopic therapy, but had a pressure above 16, they had chances of survival were very low, only 60%. But if you have a pressure which is less than 16 and then you band ligation, survival is good. So this decides that 16 and above is a bad pressure. Next, please. Now this study, which is of 2004, sorry, I said 2000, but 2004 was based on 116 bleeders. Of them, 52 patients had pressure above 20. 16 is bad for survival with endotherapy. Now, if it is above 20, if you do no tips, the treatment failure is 50% and death is 30% in 1 year. But if you do tips, treatment failure is 12% and death is only 11%. Significantly better. Next, please. These are rescue. Now, this concept of early tips. This early tips is within 72 hours, published in New England. There were people, 63, early tips versus drugs and band ligation. Early tips in 72 hours had lower rebleeding, no rebleeding, and improved survival. So reduction in pressure or decompression helps. Next. The question remains of the child's status. Next, please. So our own experience, I could get up to 2017. I didn't have it. This is to show you of about 130 patients of emergency tips in bleeders. If you will have survival which is about 18 to 20%, and MELD between 18 to 25, you can have up to 90% survival. Our patient, the one I showed you, CTP11 MELD 23, did go for a TIPS procedure because we feel if you do TIPS within 2 to 4 hours, these patients do not have liver ischemia and do well. Next, please. This is a study which is going to be again presented this year in ASLD. This is a RCT, first randomized trial of TIPS versus Danis stent and 42-day survival. Now these are patients who are active bleeders and have failed initial therapy. You can see you can place SEMS in them, that is Danis, or you can put TIPS. TIPS has a much better survival at 6 weeks compared to SEMS study. So I still feel that decompression is more physiological and is more useful. Next. Now, the reason for all this could be the blood loss and ischemic hepatitis. This study, which is also was a plenary a few years ago in ASLD, had shown that people who get ischemic hepatitis, of them death is in 2/3. Those who have no ischemic hepatitis, they are alive. Therefore, early decompression, prevention and stoppage of bleeding is vital. Next, please. You can give NAC and it can help. Next, please. So I will summarize the first part of the relevance and measurement of HVPG and acute bleed. HVPG is easy. It is simpler than doing an upper GI endoscopy. It can help you in stratification. Is it above 16, above 20? In AVB, door to needle should be less than 30 minutes. Door to scope, hopefully you have to come sometimes in night, is less than 6 hours. A junctional varix just at the GE junction, better to do glue than to do band. Failure to control, within 2 hours, change your thinking, change your line of action, your team. An emergent tips may be helpful. Post-EVL ulcer, especially if the MELD is above 17, generally we will do a Danis or a BRTO. Generally we will do less than 17 tips or emergent tips. However, Now we are improving in our tips timing. Within 1 to 2 hours, emergency tips is done. So we may go up to 25 or even higher MELD score. Next, please. Now comes the question of prevention and basic understanding of portal hypertension. I'll be very brief. Next, please. Now, no, but you see, as the HVPG increases, varices grow. 6 to 10, subclinical, more than 10, varices and ascites, they are dilated, they become large, and above 16, they rupture. Next, please. Here you will see the pictures. Next. So you have here no varices, then varices here, small, they become large, and then they bleed. Next, please. If you reduce pressure, things can reverse. Next, please. Now, this was somehow it hasn't come out well. Sorry, previous slide. This previous, can you go? Yeah, this was a study. Somehow the figure has not come. The text has come. Figure is above it. This was the first study that propranolol can prevent the development of shunts. What we did was, when you give schistosoma to the mouse, they develop portal hypertension by week 7 to week 11. Start beta blockers at week 5. Don't try to read it, it makes no sense. If you start giving at week 5 beta blockers to mice, then you have very few collaterals, significantly lower portal pressure, and no shunting. And therefore, this is a very important. This was the basic conceptual study and with Roberto Grossman to develop the portal hypertension studies in the mouse model, which is 20 grams. So we would go from the jugular, internal jugular, get into the right atrium, femoral, all kinds of things. Next, please. This basic study led to initiation, next please, of a study by Dr. Grossman, which was published in New England Journal of Medicine, that if you decrease pressure, then what happens to the study? Now, those people were divided with no varices or small varices were divided to get either timolol, that is a beta blocker, or no timolol. If the baseline pressure of the person was any, but you have achieved by giving beta blocker a reduction in the pressure. So now if the baseline pressure is less than 10 or baseline pressure is above 10, the patients who will have increase in size is more. If you have more than 10 baseline pressure, giving beta blockers has less effect. Second, prevents from primary endpoint, patients free of primary end. If you have decreased the portal pressure by more than 10, not 20, you are lucky and the varices are not growing. Patients free from primary endpoint, growth enlarge. If HVPG increases by 10 or less than 10, you have less of problem. So three things I've learned. Baseline pressure means already advanced disease. You give beta blockers, not too much. Whatever may be the baseline pressure, but you have reduced the portal pressure, it is good. Next, please. This was our next study where we took patients of small varices and gave them placebo or carvedilol. Carvedilol is much more potent. Propranolol decreases pressures by 15 to 23%, carvedilol by 40 to 45%. By giving carvedilol, we see that the growth or progression of small varices to large varices was reduced significantly. Next, please. And we also showed 8% reduction is enough, not even 10%. And this slide shows carvedilol compared to propranolol in all studies is better than propranolol. Next, please. Now the question comes, non-response to beta blockers. Almost 30% of the patients are having either one or the other contraindication. Diabetes, asthma, peripheral vascular disease, or advanced heart or kidney problems. You can't give beta blockers to them. So 1/3 is out. Another 20 to 30% never tolerate beta blockers, have side effects, decreased libido, sleep, or lightheadedness. They can't do it. So ultimately, the people who get is about 1 in 2. Those who get, only about 30% respond to propranolol, 50% to carvedilol. So maybe 3 out of 10 with portal hypertension finally get beta blockers. So do we have options? One, you can never decrease the heart rate because the blood pressure goes down. How can you decrease heart rate if the BP is 90? You can add Evabred. The second drug I am going to discuss is a statin. Third will be metformin. There are many others which I cannot, but let me tell you, if there is a large varix and there is non-response to beta blockers, do band ligation. Next, please. Evabred is the one which blocks the funny channel, especially binds to them. This is very commonly used in cardiology. This is the first study, and I tell you, it is like, it's a pleasure to use Evabred plus carvedilol. Next, please. What it does is, if you achieve a target, if you achieve get to diabetes versus carvedilol plus standard therapy. Now you can see that survival in this limb was significantly better. Although if your carvedilol achieves the heart rate is much better. But if you see that responder versus non-responder, you will see those who responded means were able to achieve target heart rate. In them, you have much better outcome than the others. The difference is trend, but the message remains: combine ivabradine with carvedilol in those where blood pressure goes down. Next, please. These are very new studies. Now comes the statin issue. The statins, they try and inhibit KLF2 and rho kinase pathway. By doing this, they are able to increase the endogenous nitric oxide, endothelial nitric oxide synthase, and this increases the nitric oxide. It decreases stellate cell contraction and HVR, and portal pressures are decreased. Simultaneously, it also causes several cytokines and other factors to be decreased. Finally, statins are known to decrease some fibrosis, portal pressure, and inflammatory response. All these are in experimental studies. Where are the human studies? There are only 2 and large studies, and I'll show you that. Everything else is experimental. Next, please. This study, which is published in Gastro, was secondary prophylaxis. Patient has bled. After bleeding, one group gets simvastatin, other groups does not get. What it shows that simvastatin never decreased bleeding. It never decreased portal pressure additionally, but decreased post-bleed mortality. Here you can see that proportion free of bleeding, no difference, but mortality somehow. So statins may work through many other mechanisms, protection of endothelium, blah, blah, but not by portal hypertension modulation. Next, please. The next slide, which is a study which we published this year, very difficult to publish. It's a negative study. Hemodynamic effects of adding simvastatin to carvedilol for primary prophylaxis of variceal bleeding. What we did was one group get simvastatin plus carvedilol, other group gets carvedilol alone. Now, this was done to see that those who get combination therapy have no added advantage. So, the fact that carvedilol is a potent beta blocker, can simvastatin add something? Normally, on propranolol, simvastatin has been shown to decrease pressure by 8 to 10% or so. But carvedilol is so potent, it does not give any help, and the number of people who were responders also did not make any difference. So simvastatin does not improve carvedilol. In this study, everyone received carvedilol, then one group continued, one group added on to simvastatin. Next, please. Now, this is a very interesting study. Unfortunately, we could never submit it for publication properly. It's just use of metformin. Now, metformin is a very, very important drug. It has many pathways. You know all those pathways. Now, can metformin decrease pressure? Metformin actually modulates stellate cell tremendously. Experimental study, and this is the clinical study. When you give metformin to standard therapy versus standard therapy alone, portal pressure reduction of more than 10% or so was significantly more, 60% compared to 14% or so. So this is just to show you, and we have data, patient has 17 or 18 HVPG, it came down to 7 or 6. So all our patients with cirrhosis, with NASH today would be put on, unless decompensated, on metformin therapy. Next, please. This was published oral at ASLD, but not published, presented there. Now, this is very briefly to show you the gastric varices. You are fully aware of it. On the lesser curve, 70%. On the greater curve, 21%. Isolated gastric in the fundus, 7%. Or ectopic varices, like this is duodenum, is about 2% or so. Next, please. Based on this, the risk is there. IgV1 bleeds maximum, then GOV2, and least is GOV1. Next, please. Yeah, here you can see large GOV2. Next, please. One more, hold on, please go back. Sorry. A very important part in the classification. Okay, please continue. Now, here is acute gastric. Please start. I'll tell it later. Please start. Yeah. Now, how bleed? Everyone is some do two injectors blood in this, so, and an aid will be there which will be alterated. Flush the dead space so that your needle is not blocked. Next slide. This is a simple flow diagram. A gastric varix with acute bleed. If it is IgV1, as we saw, or GOV2, then you inject glue. Bleed is controlled. Secondary prophylaxis, if needed, by glue tips of Yatio. GOV1 managed as esophageal varix. However, if the bleed is not controlled, should you do a second glue? Possibly no. Should you put a balloon? Possibly no. If it is a generalized portal hypertension, it is much better to go for BRTO if there is a shunt available. If there is a shunt available, there is always a possibility, and in that if the MELD is above 17, if the patient has portal hypertensive gastropathy, if the size of the varix is more than 20 millimeter, and if the varix has red color sign, this is a high risk gastric varix. Esophageal 5 millimeter, gastric 20 millimeter. RCS is same. Presence of PHG and presence of MELD above 17 are more bad risk factor for gastric varices. Such patients need prophylactic because if the gastric varix bleed, mortality is 50% in 1 year. Next, please. Cannot move, Izumi. Yeah. So here is the high risk I told you, and such patients need glue or PRTO if there is a shunt available. Next, please. TIPS is not used for primary prophylaxis. Next. I have covered with you most of this. I will briefly cover, I have also covered beyond beta blockers, new drugs. Very, very important concept of portal hypertension. Can you prevent decompensation and how? And how decompensation occurs? Why patient get ascites? Next, please. So reduction in portal pressure improves outcome in cirrhosis. Next. Now, this is a study which we just published in American Journal Gastro. Patients who have got HVPG more than 24, HVPG less than 10, yellow is 20 to 24. You can see that the cumulative incidence of decompensation over time. Higher the pressure, faster the decompensation. The incidence of decompensation is high. If the pressure is less than 10, you mean it is not clinically significant. Your decompensation is much less. Next, please. So above 20, terrible. Now, this is a very, very interesting slide, which we have abstract but never wrote it up. Portal pressure is 6, 7, 8, 9, 10. This is subclinical. It is not clinically significant, but see the beauty. Rate of decompensation with 1 millimeter rise increases. So before it is 10, you can still have ascites. Before 10, you may still have jaundice. Before 10, you may still have HE. You may not bleed, but you may have varices below 10. Next, please. Now, this is a slide from Abraldis, a very interesting paper. Now, you have given beta blocker, and your reduction is more than 20%, not 10. Or the pressure is less than 12. What is the difference? Those who respond means more than 20% reduction in HVPG or baseline less than 12. So those who respond have less variceal bleeding, less ascites, and improved survival. Next, please. And then comes this study, our study in hepatology. Abstract, those who have pressures less than 10 compared to those who have pressures above 10. You can see that rate of hepatic decompensation is much better. The same abstract I showed you. Next, please. We never wrote it, but others have written it. Next, please. And that comes as a study in Lancet, 3 years after our original work. This is Predesky study. Beta blockers prevent decompensation in clinically significant. We were in clinically insignificant. But what it shows is that first, child's A and B patients dominantly. Next, please. If you give beta blockers to them, not C, child's A and B, you will see that there is a significant advantage compared to placebo in the beta blocker group as far as incidence of primary endpoint, that is decompensation. Less decompensation and placebo, more decompensation. Next, please. Now I summarize and conclude in last 2 or 3 slides. First is relevance of liver pressure in clinical practice of hepatology. It can help you differentiate non-cirrhotic from cirrhotic. In non-cirrhotic, HVPG is normal or near normal, less than 10. But intravariceal pressure, its clinic pressure may be 20, 30. In acute bleed, about 20 millimeter, we do every variceal bleeder gets endoscopy and pressure, same within 2 hours. If he has high pressure, straight to tips. You also can stratify your patient that this patient is not likely to stop. He may, but he may not. Chances are more. Next is growth of varices. Here in acute bleed, 20 millimeter is high. In growth of varices, suppose the patient has a pressure of 10. You reduce it to 9, 1 millimeter. That is 10% reduction. That's pretty good. Can you believe 1 millimeter reduction and his decompensation is delayed? If you reduce 20%, nothing like it. But in these compensated cirrhosis, higher beta blocker required. In advanced cirrhosis, there is lot of noradrenaline. So small amount of beta blocker is good. But in compensated, there is less of noradrenaline, higher beta blocker is required. For secondary prophylaxis means patient has, primary prophylaxis, you require 20% reduction from 10 to 8 or 20 to 16. 50% will have non-response, they need to go for EVL. No statins, nothing else works. Secondary prophylaxis, patient has bled. You don't want him to bleed again, so after day 6, you will add beta blockers. For patients with SBP who have got SBP once, not during SBP, to prevent further infections, mortality, you can give and it decreases by 10% mortality. Portal hypertensive gastropathy, colopathy, you give it, whether it benefits, no. Gastric varices, not much benefit. Cancers, can it prevent? We don't know. Next, please. Prevent rise in pressure. Try to reduce pressure. That is the whole aim. Like hypertension treatment. Bring it to normotensive, managing your heart, your brain, your kidney flows. Same is true for portal hypertension. Prevent the rise, and in fact, if it is high, try to reduce. Primary and early primary. Primary means varices are large. Early primary is grade 1 or 2 small varices. Pre-primary is high pressure but no varices. So I have not discussed pre-primary, which is under review. So early primary or primary. Our drug of choice is carvedilol. If it is bringing the BP down, add ivabradine. This will help the patient reduce decompensation. Non-responders, you may try any of these, but we don't know. Splenic artery embolization, BRTO, PARTO may be of some help in them. Portal hypertension is a huge area. I might have skipped many, might not have addressed relevant questions. I'll be happy to answer. And thank you, Dr. Lau APASL, for allowing me to give a longish talk on portal hypertension. Thank you.
Thank you very much, Professor Sarin. This is truly state-of-the-art and very up-to-date lecture on a very important topic related to the chronic liver disease. Well, I can see there is a lot of questions and also the attendance to our webinar. Among those questions, I take the liberty to choose a few to address and hope you can address. You mentioned about the use of carvedilol, and it was asked what would be the recommended dosage of carvedilol for the treatment of portal hypertension. So,
the target heart rate should be around 60. Carvedilol is given as 3.125. You can give it twice a day. Maximum dose for cirrhosis we have used is 25. Cardiologists go up to 50, but upper limit is 25. But do remember, patient who has got ascites or refractory ascites, don't use carvedilol. It will precipitate HRS very fast. So it is better to use in child A or B, early B, not too late.
Another question is, I think, very relevant about the liver pressure. Not a lot of centers have the facility to measure the liver pressure as you can in your institute. Any alternatives or non-invasive methods that we can rely on to help us to manage those patients?
Well, there is no reliable method. There are radiomics, and one of our very good friend, Dr. Xiaolong, is trying to find alternatives, but none of them is reliable. But I can tell you the platelets are the most accurate way of finding the pressures. If the platelet is above 100,000, relax. That's the only thing. Other than that, you can do fibroscan, but it loses its value about 23. Whether it is 23 with grade 2 varices or it is 40 with grade 2 varices, you cannot differentiate. So I think HEPG is very simple. Believe me, it takes 3 minutes to 5 minutes to do a pressure study. And we can do some webinars on that. But right now, not many non-invasive methods.
I can see that Professor Domexi would like to raise a few questions. Am I correct? Could you please raise your questions then?
Yeah. First of all, thank you very much. Some of my friends gave me a telephone call for the disaster, earthquake disaster in Turkey. I was in Izmir for the weekend, and I really felt very, very terrible. But now I'm safe. Thank you very much. The second point is, of course, especially thank you very much for the Professor Sarin. It's a wonderful talk, really. He summarized very well. And but I would like to emphasize that ultrasound, conventional ultrasound and Doppler ultrasound is the first step for the assessment of the portal hypertension as a non-invasive method. Actually, 1981, when I was studied at Chiba University, we published one of the study just showing the collateral veins in portal hypertension by ultrasound. But ultrasound is not showing the collateral veins, or also giving very important issues for the morphology of the liver and also flow of directions of the portal system. I think as Professor Sarin pointed out that ultrasound is very important for the assessment of the portal hypertension as a first step. Thank you very much.
Thank you very much, and I think that we have quite a few very good responses for the discussions and the talk. With the time limit, I think we need to close the sessions. But before that, I think our presidents of APASL would like to make a few announcements. So Professor Tawandi, please.
Good evening. Thank you very much, Professor Lau, and thank you for extensive talk by Professor Sarin on the topic of portal hypertension. I think there are a lot of attendance, not only in the Asia Pacific area, but also in many parts of the world, as I can see from the attendee name. By the way, before we close this webinar for this week, just to remind all of you that we're going to have this webinar every Saturday at 8 Beijing time. This is the first episode of this series. But next week we're going to have the same with very important topics, and every Saturday on at 8 on Beijing time. One of the reasons we moved to 8 p.m. This is going to be more practical for many parts of the world. And before we close the webinar, please be our guest to the APASL 2021. We have decided to go virtual because of the COVID-19, especially for the second wave of the COVID-19. But the virtual thing is not that bad because we have reduced the registration. The abstract submission still open, so please join and please publish your work during the APASL 2021. See you during the APASL 2021, and good night.
Thank you very much. I would like to close the sessions now. Thanks for coming, and hope to see you next week.
Thank you.
Bye-bye.